Good morning, and welcome to the second session of In Conversation. I'm Victoria MacDonald, and I'm the Health and Social Care Editor for Channel 4 News, and I have the greatest pleasure to have Dr Layla McCay, Director of Policy at NHS Confederation, with me today. I have to remind everybody that there are some PERDA rules around, there are some slight restrictions, but I can't be held responsible for your questions, so, go for it, and Layla will either answer them or not. Can I introduce her? She is Director of Policy, as I said, at the NHS Confederation, trained as a psychiatrist. We've just been discussing how once a psychiatrist, always a psychiatrist, so she will be having a look at your questions and wondering why you've asked them in that way. And we have agreed that you never ask a yes-no question. She has such an amazing CV that I haven't got time to go through it all. But there were lots of things I didn't know about, including your work with the WHO and the World Bank, and several global NGOs, various academic posts. If you need to know any of this, please do go and look it up. Needless to say, she is very impressive indeed. The career shift from psychiatry to health policy is a really interesting one, and why is psychiatry so awful that you just couldn't face it anymore?
Well, I actually only planned to jump out for a year. There was a sort of fellowship placement type thing at the Department of Health, and at the time, I didn't really know anything about health policy. I literally thought a civil servant was a servant. Like in a house, when I heard of the name of the job. So when this came up, I applied on a bit of a whim, and then I found out that I actually really, really like working in policy. And, the opportunity to have that impact at the national or the international level is just so interesting. And there's so much complexity to it and so much opportunity to do something positive. So after my year finished, I did briefly go back into psychiatry, but now my head had been turned by knowing that this other profession was out there that I really like to do. So when I got the opportunity to move back in, I couldn't resist.
Yeah, and nothing to do with the fact that in psychiatry you have to deal with real people.
Well, there's pros and cons to that. I always think about having left medicine, and when you're working one-to-one with patients, there's quite a lot of instant gratification. You help somebody and they get a bit better and they say thank you very much, and they go home and you feel, oh, I did something useful today. But I think that, and anybody who works in policy will know, you really are in it for the long game. You'll do a bit of influencing, you'll tweak some wording, you'll try to get something into a policy, and then in due course, it could have a much wider impact, but you don't necessarily see that for years. You might not personally ever get to see the impact that it's having in a positive way. So I think that in many ways, it was quite enjoyable being right there face to face with a patient, but it's also really gratifying, I guess, doing policy.
Okay, so one of the things that we want to talk to today, to Layla about today, is her new book, which is called Breaking the Rainbow Ceiling, How LGBTQ plus people can thrive and succeed at work. Now, I have to admit, Layla was only put into the slot at the last minute, not because she's not loved and wanted, but because she was more important than the person who was meant to be doing it. And I haven't had time to read the book, but I've read lots about it. So just give me a quick summary.
So essentially the book is about why LGBTQ plus people are less likely to make it to the top jobs in most sectors and most countries. And it's a topic that I got sort of personally interested in because I ended up hearing that at an interview for a fellowship I wanted once, the panel had discussed not selecting me specifically because I'm a lesbian. And I think we all know that there's lots of prejudice and discrimination that anybody from a minority group is likely to face. But I think there's a difference between sort of theoretically knowing that and then seeing it genuinely, specifically applied to you. So then I got interested. I started looking into it more, and I was really keen to read a book on the topic, and I couldn't find one. And I thought, well, I suppose I could write a book, and here we are.
So just out of interest, how were you told that? How did you find that out?
Oh, only because I happened to know somebody who had been on the panel, and a couple of years later we were having lunch, and he told me it as a funny anecdote, and he was chuckling about this, and I was completely shocked. I didn't even know how to respond to it at the time. And then, I went home and I started second guessing every decision that had ever been made in my career. Obviously, I'd had all sorts of interviews that I'd not been successful in my life, as you do, and I'd assumed it was probably because, somebody else performed better or better connected or who knows, the various reasons. But I hadn't ever really thought maybe somebody didn't like that I'm gay. And then once I thought it, I couldn't stop thinking about it.
So when you were researching the book, what was sort of the first question? What were you asking yourself?
Well, the question that I wanted to understand is, well, first of all, I wanted to know, is this actually true? Is there a disparity? And then I came up with all these really, really compelling facts to show that there definitely is a disparity, even though people don't necessarily clock it or think about it much. So, for example, in the 500 CEOs of the Fortune 500 companies, America's biggest companies, only 3 of them are LGBTQ+. And that is a really, really small, small number.
Or
3,
admitting?
Well, that's another question, isn't it? Because there's no way of knowing how many people are LGBTQ+ in the world, in your organization, in any particular role, because it very much depends on whether people feel safe and willing and able to tick that box. And lots of people do not. So certainly, I interviewed more than 40 very senior leaders for this book, like ambassadors and CEOs, even one of those Fortune 500 CEOs. But for everyone I interviewed, there were loads of other people who were not feeling able to be out in public about being LGBTQ+, because they believed that it would have a negative impact on their job. So yeah, there's definitely not a way of knowing how many people in any role are LGBTQ+. There's only a way of knowing how many feel that that is a thing that they're able to talk about and still thrive and succeed in their job.
I mean, I know this is an obvious question, and I apologize, it's a terrible journalistic thing, but what is the impact of that? And secondly, when they say that they didn't feel able to talk about it because they thought it would affect their job, how did they know? How did they come about? What evidence base did they have for thinking it would affect their job?
Well, I mean, I think that anybody who is LGBTQ+ has grown up in a context of experiencing homophobia, biphobia, transphobia all the time from their families, from their school, from their friends, from the media, from politicians. There's all sorts of really negative messaging, and then quite often, if you know at an early age, and you'll know you have to tell someone, and quite often you'll experience quite a lot of rejection. So people are used to being rejected and having these really unpleasant reactions, and knowing that we live in a world where being LGBTQ+ is perceived as a bit different, and often in a way that people don't perceive as a good thing. If we think, for example, it's only been a couple of decades since you weren't able to be a diplomat in this country.
Get married.
Yeah, exactly. I mean, recently the FCDO PermSec issued a special apology because for years and years and years, if you were an LGBTQ+ person, you just could not be a diplomat. And then thinking of things like in the US, there was this concept called the Lavender Scare, which was essentially this witch hunt. Anybody who had any position in government who was thought to be gay would be found through all sorts of nefarious means. And if the confirmation was that they did seem quite gay, they would be fired from their job. And, it had such a massive impact on what people thought about LGBTQ+ people, about people's careers, because obviously those were people who were on the career ladder that were kicked off with tons of stigma, and the impact of that persists today. So we're still seeing lots of countries in the world where there are restrictions on people's job opportunities, as well as all sorts of other opportunities because they're LGBTQ+. So if you are a leader and you're thinking, gosh, I would like to be out, and there's loads of really good reasons for being publicly out in the workplace, like when you're not, it's like you're not able to be your authentic self. You're kind of trapped in this complex bit of a nightmare of having to hide who you are, avoid questions about what you did at the weekend, police yourself in terms of, you know, how you act or behave or what you say, always worried that somebody is going to find out and use the information against you. And all the people I spoke to just said that they were absolutely worn down when that happened. And when they did come out, they felt like they were able to perform so much better. They were able to have better relationships. They were happier at work. And you can look at the data of surveys, and it shows that people have this huge jump in job satisfaction once they are out, even though that puts you at much more risk of bullying, harassment, and discrimination. But when you speak to people and say, why did you come out? What made you make that decision? Often they were like, it was such a nightmare trying to hide this. I worried about it too much. But also they would be like, you know, I knew it would be difficult, but actually I did it for altruistic reasons, because there are so few senior LGBTQ plus role models in different sectors. We have some brilliant ones in the NHS, but there still are, you know, disproportionately few. So people think, I will come out, and then other people at more junior levels can look up and say, hey, look, there is an LGBTQ plus person like me thriving and succeeding in this organization. If they can do it, so can I. And it has such an impact on people's aspirations and self-confidence and self-belief. And that's really why most of the leaders I spoke to said that they did it in the end.
Yes, talking about the NHS, and also you are the executive lead of the Confed's Health and Care LGBTQ plus Leaders Network. Mm-hmm. So how is the NHS doing? How are the staff surveys showing that this is something being dealt with within the NHS?
I mean, I think that the NHS is very aware of this challenge. Only for the past few years have we been able to specifically analyse the staff survey through the lens of LGBTQ plus staff members, and you can split that down because, of course, people have different experience, whether you're a lesbian or gay or trans or bi or whatever that may be. But you can split that down now, and it is so interesting because, of course, it gives you this useful information, and it shows you that if you are an LGBTQ plus person in the NHS, you are likely to be having a worse experience than the overall staff, and that's in almost every single domain, from things like bullying, harassment, and discrimination, loads of stuff in terms of people's managers and their peers and patients and visitors, but also in terms of how they're being managed, how they're interacting, how their sense of belongingness, and whether they would recommend the NHS to other people looking for a job. Those things are so critical, obviously. You know, we really need to recruit and retain people in the NHS. And if you analyse the staff survey in that way, what you can see is that we are less good at recruiting and retaining LGBTQ plus people because they're having this worse experience. And I think it's so interesting when you're looking at this question, which starts out feeling like a kind of small, contained question, and then you're looking at it in the context of somewhere like the NHS, you know, one of the biggest employers in the world, and what we're seeing is that we're not giving people what they need to fully thrive and succeed. So there's a lot of opportunity. But I think it's really positive that we've started being able to split down the staff survey in that way. And in fact, you can do it in your own organisation. You just tick the various boxes and it'll show you what your organisation looks like from that perspective. Because once you've got the data, I mean, you can turn that into knowledge and then you can take action on that knowledge. And I think that is one of the really exciting, positive opportunities here. The question is, are people actually doing it? There's not a specific requirement to monitor that at the moment.
Well, I was going to ask if this hasn't been happening for that long, and I'm actually surprised by that. But are there some good examples of where that information has been taken and turned into a positive?
Yeah, absolutely. And a couple of years ago, we worked with about 13 different NHS organisations to pilot different things that we can do to really help support and empower LGBTQ plus staff. And one of them is that understanding the information and really using it in a useful way. There's things around visibility, as I mentioned, in terms of senior leaders, in terms of mid-level managers, just being able to have more visibility, that people are out there in the world. There's a lot of assumption that say you are an LGBTQ plus person, you're in some kind of leadership position, and you think, my team know it's fine. Like, I'm out, I'm having that positive impact. But in fact, what the research tells us is that you actually have to specifically tell people, like, it's not just magic that people will guess that you're an LGBTQ plus person and think, oh, look at that representation. If you want to get the positive benefits of that, you sometimes have to be quite explicit, you know, talking about it in staff meetings or doing a blog or all those sorts of things, sort of personal stories. Quite a lot of the people doing the pilot found one of the most helpful things in driving understanding and inclusion in their organizations was being able to share personal stories from staff, which really, you know, helps make the theoretical concept of equalities and inclusion and discrimination a bit more stark when you think about it in the context of your own colleagues.
So you've done, I mean, you've covered so many areas in your policy career, and I'm reluctant to leave this one, but before we lose time, obviously there's an election on. Obviously there's an opportunity to talk about policy without criticizing any of the parties. I'm under the cosh here. Tell me what you would like to see the next government approach in their first priorities.
Absolutely. And let's see how to do this in an appropriate manner. I think that there's so much talk about the need for improved productivity in the NHS, but what we consistently see is that the NHS does not have the tools that it needs to be able to deliver on that productivity ambition. So, for example, you'll hear me talk a lot about capital, because, you know, the amount of capital that the NHS needs to actually just be able to do its job and be productive and fix the roofs and stop the leaks and repair the machines and just be able to maximise the productivity from an estates and equipment perspective is massive. But the capital budget just keeps being raided for other things, and people don't quite want to accept where that backlog of capital funding has actually got to. So really, I think that what we need to see of whoever ends up getting in this election is a genuine focus on capital. Another thing about productivity is obviously the workforce, and we'll see all sorts of promises from all the parties about X number of whatever type of clinician or whatever it may be, but actually we've done this analysis. We have an NHS long-term workforce plan. We know what is needed to get productivity from a workforce, and we need to fund that plan, because that is absolutely critical to getting this going forward. I think we're keen to also see a bit of focus on what does it mean to deliver more care outside of hospital. And in this world where there's so much demand, these waiting lists, you know, are really, really challenging. How do we actually help intervene at an earlier stage, stop people needing to go into the hospital? And it's going to be all about prevention. We all know that. We hear about that all the time. But the question is, what is the new government going to do to make that real? There's a lot of dabbling around the edges, but really thinking about how do we invest and how do we support primary care, community care, all those places that are really going to need to be strengthened to turn this from some kind of soundbite into reality. There's so many lovely examples all over the whole NHS of where that is happening, but we consistently hear from our members, you know, they're having to disinvest in things because they need to balance the books. So I think that is a key one for me. I'd also just say, don't go reorganizing the whole thing. So tempting to just go, I'm here, let's do a massive reform. And I mean, it's not the way that the NHS is set up that is causing this issue. And just restructuring everything is such a massive, massive time suck for the NHS. And what we just really need to do is focus on the things we know we need to do, come up with the sufficient resources to be able to do that. Keep your eye on the prize with the long-term workforce plan and an equivalent thing for social care. And think about healthcare not just as an NHS concept. I mean, only quite a small proportion of everybody's health has got anything to do with the NHS at all. And there's all these other government departments that have an incredible impact on health. But for some reason, I mean, not for some reason, it's actually pretty hard to coordinate across departments. But we really do need a national strategy that focuses all these different disparate departments on how do we actually work together on common goals to improve not just health care, but health overall. So that's what I'm hoping to see. Let's see what all the manifestos have to say.
Yeah, I'm sure it will happen. Devolution, actually, you're talking about the other government departments. Have you looked much at what that impact might have if you could devolve health further, if you could bring in housing departments, social care, mental health, all into the one space? Because we've seen it done in some areas, but not in others.
Yeah, and I would direct you all to a rather nice little report that we've recently published. What is it called? Can't remember. The word devolution's in there, so if you stick it into the NHS Confed website, it'll probably be the first thing that pops up. It was published maybe about 2 months ago, and it really looks at examples where, yeah, being able to devolve and let local leaders lead has these huge opportunities. I think, this is despite all the reforms, this continues to be one of the most centralised healthcare systems that we have. And I think a big question for the new government will be, in the ambition, we've developed ICSs, we really want to be behind making those work. But what stops making ICSs achieve the ambition is holding on as well to things at a centralised level, and thus you're getting, this conflict, and just really understanding how can we best empower local leaders to lead for their local populations. It's a bit of an existential question, but actually there's loads of good examples, as you say, of how you can do that, and we'll really be hoping that they learn and figure out some new approaches.
Well, how optimistic are you that these messages are getting through?
I mean, it's hard to say, isn't it? I'm reasonably optimistic. We hear a lot of positive things from the various parties going into this government. I guess the question is, how will that then, make its way into policy and practice after July the 5th? And how positive? I think I'm reasonably optimistic. I suppose it depends what part of it you ask, but I'm reasonably optimistic that everybody recognises the NHS is one of the public's absolute top priorities in this election and in life. And right now, there are so many challenges, and we need this service. We care about this service. We are doing so many brilliant things already, and I believe there are lots of little things that we can do that will genuinely make a shift. I think that all governments recognise this need, and they are willing to listen because they know that they need to do something. And I think there's this brilliant opportunity for Confed and others to help them think that through, to look at the evidence, to look at what cool things are being done by you folks around the system, and how to implement them. I genuinely think that we can make a difference.
I wonder how optimistic you're all feeling about what's coming and what changes will be made, or changes that the NHS needs. If there are any questions, please do put your hand up. We have some mics. Helen, there. Right off the mic. Is there a microphone somewhere? Or is it, oh, here it comes.
Do you want to run up and borrow this one, Helen? Oh no, Charlotte's bringing it.
Not that we all know each other, of course.
Thank you. Thank you. And thank you, Layla. I have so many questions, but I'm going to follow on from what you've just been talking about. So I remember, I won't name names because Purda, but some years ago I was asked by a Secretary of State, how many doctors and nurses is this winter money buying? And I was desperate to say, but not brave enough, that we'd make more impact if we actually spent the money on good data analysts.
If we ask you how long ago that question was asked, we'll be able to work out.
But my question is, you talked about the long-term workforce plan. The long-term workforce plan doesn't cover managers and administrative staff. Is there a world in which you could see a proper plan being developed to support the growth in what's needed in terms of management of the NHS? I think we're unlikely to get politicians saying they're going to promote and have more managers, but could we stop them saying we're going to have less managers?
I think you're too late for that one. I think that one's already been said at least once this week.
Quite. I think the soundbite of we're going to get rid of managers just plays out quite well with certain parts of the public. But we know, looking across the whole world, that the NHS has a disproportionately small amount of managers. We are really, really poorly managed in comparison to really significantly more managers in all sorts of other healthcare systems. And obviously, in this country, in all sorts of other sectors, we have this massive, massive organisation, and calling for fewer and fewer managers is not the way to achieve productivity. So I think that there's a lot that we as Confed, and that everyone who's having those conversations can have to try to explain that. Try to explain that you could get rid of all the managers, but then you would have all the clinicians having to do those roles, and potentially in a significantly less efficient way. So understanding productivity, I think, is probably the theme of what my ask is, because managers can deliver that productivity. Reduce the number of managers, you reduce that opportunity. So yeah, I think you're right, Helen. We need to keep making that case. And the case is to explain why this is in fact an investment in productivity that has got lost, I think, in a bit of the public rhetoric.
I always think the problem somehow is that you talk about NHS managers and it's sort of an amorphous mass. You know, the public doesn't actually understand specifically what an NHS manager does. And you could be talking about the chief executive of a trust, or the chief executive of an ICB, or whatever. But generally people don't know. They think about people going around with clipboards, you know.
Well, absolutely. And I think it can be helpful to have scapegoats, can't it? And it can be helpful to have some group at which to point a finger. But being able to really talk more about how things are being achieved, and management as a key skill within part of that team. As Helen says, other specialties as well. Like we do quite a lot of really interesting work on digital innovation, and I'm just really struck by not having the brilliant plans in place that we need to get the people to actually deliver that. We can talk, you know, at a high level about your aspirations for digital innovation, but if you don't have the digital specialists in the NHS, the analysts there, the people who are able to make this actually a reality, you can hold up as much shiny pieces of tech as you want, but they're not going to deliver the digital transformation ambitions. And so yeah, I think we need to be more excited about the non-clinical roles in the NHS, because those are the roles that are going to deliver the innovation and transformation that are being promised left, right and centre, and that we, obviously working in the NHS, really want to see happen.
Well, ironic that you're talking about it in the week where there has been a massive cyber attack, ransomware attack, and another IT outage in Cornwall, I think. The infrastructure, as well as the expertise, as well as the management that needs to be doing this.
Absolutely right. It's like the amount of things that are behind the scenes investment in the NHS that the public don't automatically think about until something goes wrong, like these cyber attacks, it's huge. And disinvesting in those sorts of things in order to shout about having reduced whatever kind of non-clinical spend, I mean, it's such a false economy. And obviously, if you do choose to do that, you kind of live to regret it, don't you?
Are there any other questions anybody would like to ask? I mean, I just had one more, which is about the silos that everybody talks about, the NHS and social care. You were talking about prevention before, but this idea of, you know, the secondary care not working enough with primary care, working with prevention, have you seen an improvement in that? Do you think, for instance, the ICSs has helped with that?
I mean, I've seen so many examples of where that is working well and where that is improving. But I think it's just clear that it is hard at the intersections between those different things. And our legacy systems have made it harder. You know, people have like working on different IT systems. They don't have good ways of communicating and sharing information. All of that stuff that we're working on now and trying to bring a bit of interoperability, a bit of cohesion. ICS is providing some mechanisms for that sort of shared objectives and integrated working, but it is hard. And a lot of the work we've been doing at the Confed this year has been really supporting people at those intersections to try to understand how to make it work better. And people are so keen to make it work better, because at the end of the day, it's not like patients care about an intersection. They just want their care to feel fairly joined up, and it's frustrating when that can't be delivered. But I do think that the ICSs have got so much more to deliver and be realised as we move forward and really strengthen this way of working. And hopefully we're moving towards a future where it does feel a lot more smoother and integrated.
Well, that's a beautiful, optimistic note to end on. I would be interested to know, you can tell me later how optimistic you're all feeling. But thank you, Layla. That does give us a beautiful vision for the next government.
Thanks very much.
Could you thank Layla?